I'm Morgan Cooper, and this is Bernie Ekman and Claire DeVinny. We're here to discuss how race affects increasing rates of maternal mortality in the United States. This chart reveals the trend of increasing maternal deaths since 1986 in the U.S. The Center for Disease Control and Prevention, also known as the CDCP, is an organization of seasoned physicians working to better the health of Americans with information and regulations. The CDCP compiled this data in order to gain a better understanding of how many new mothers were dying in the maternity ward, as well as soon after their fatal visit. A variable that should be considered when examining increasing rates of maternal mortality in the U.S. is race. So, how is the increasing rate of maternal mortality in the United States affected by race? Well, maternal mortality rates increase significantly due to outdated medical practices still being used today, inaccessible and overpriced healthcare supplies, and hospital complacency and bias towards women of color. New women of color are affected negatively by the outdated maternal medical practices still being used today. Dr. Amani Shekete Ani, a former professor of Africana Studies for the University at Albany, discussed the overuse of cesarean sections on women of color. She suggested that it was a form of oppression and that women of color would usually be forced to have a surgical birth over a live birth. Candace Johnson, a political science professor, interviewed women of Mexican origin living in Texas about their maternity ward horror stories. Many of them had to experience sterilization and unwanted surgical birth at the hands of the doctors they were with. Leah Campbell, an author known for her articles on parenting and general health and wellness, shares the story of Elise Salazar, who suffered mistreatment and neglect in the maternity ward due to racial stereotypes. She had to undergo tons of labor pain because they wouldn't administer an epidural for her. She had to prove she was in enough pain first. Dorothy Roberts, JD, a public scholar and intellectual who focuses on gender, race, and class in legal issues, discussed the issues with the outdated practice of race-based medicine. She suggested that race-based medicine was usually looked at unscientifically when it should be looked at scientifically. Usually what would happen is the stereotype is that women of color are more able to sustain pain, and usually they aren't given the proper care or are neglected while giving birth or after.
I'm Bernie, and poverty has had a significant effect on the maternal mortality rate for women of color. These women are unable to access sufficient health care due to their location and lack of funds for care. Christina Novoa, a policy analyst at American Progress for Early Childhood Policy with a doctorate in developmental psychology, discusses with Jamila Taylor, an international women's health expert at American Progress, how studies show that prenatal care tends to be of lower quality and the women experience more complications for cases of women of color. This is the situation for if they receive care at all. They also state that African American women earn 63 cents per dollar that white men earn. Women of color are more likely than white men and women to work in jobs that lack crucial benefits such as paid sick days and family leave, as well as flexible scheduling. Novoa and Taylor say that unsafe neighborhoods, insufficient access to healthy foods and good healthcare services, and employment opportunities contribute to the high maternal mortality rates for women of color. All these situations are due to poverty and could be remedied by lowering the poverty rates. Women of color tend to live in communities affected by poverty, but could receive better housing, go to better doctors to receive the care needed, and obtain nutritious food for their child if they were not affected by poverty. Candace Johnson, a professor of political science with her expertise being in maternal health, reproductive rights, and women and gender politics, states that the highest maternal mortality rates are in low-income countries, including sub-Saharan Africa. The World Health Organization, which is an organization that studies the health of all the public, agrees with this statement, stating that maternal mortality is higher among poor communities and in rural areas. Hospitals suited for women of color would be accessible, and they would have enough money to pay for their visits and any supplies needed for their child if they were in better financial and living conditions.
I'm Claire, and I have the scientific lens. My thesis is that hospital bias and complacency heightens the risk of maternal mortality for American women. Dr. Amy Metcalf, an assistant professor at the University of Calgary, who has a specialization in study in chronic diseases in pre and postnatal care, oversaw a study that found that 83.4% of deaths occurred the day after delivery, which would indicate that most maternal mortality deaths aren't happening in childbirth, but afterwards of cases that are probably preventable and within the hospital's control. Elizabeth Howell, who's the Assistant Dean and Professor of Obstetric Gynecology at the Icahn School of Medicine at Mount Sinai, founded a study that analyzed hospitals' rates of maternal mortality based on the race of their patients and classified hospitals as either high black serving, moderate black serving, or low black serving. And it was found that there were significantly more cases of maternal mortality in high black serving hospitals and moderate black serving hospitals than low black serving hospitals, with 29.4, 19.4, and 12.2 out of 1,000 deliveries ending in maternal mortality, respectively. An NPR podcast about maternal mortality found that an estimated 60% of cases of maternal mortality are preventable. These statistics could lead scientists to conclude that cases of maternal mortality are often because of preventable causes that hospitals simply fail to notice or diagnose because of bias against patients of color, or because of hospital inefficiency, such as the women have to wait a long time to get the tests they need, or other causes like that. Some limitations to these sources are that most data about patients are taken from the National Inpatient Sample Database, which takes a sample of 20% of everyone in the United States who's been to a hospital. However, it doesn't, because of patient anonymity laws, it has to, it is barred from disclosing repeat instances of hospitalization of women, so it doesn't show dangers in pregnancy that may have been caused by a previous pregnancy or by another admittance to the hospital. So our solution was that review committees, specifically meant for maternal mortality and morbidity, could be formed within hospitals to investigate cases of maternal health crisis and publish the information. The implications of this would be that it would improve access to quality care. If patients know their doctor's record with maternal mortality and morbidity in patients, they would have an easier time choosing which doctor they think would be right for them. For example, if a doctor is specifically prone to giving C-sections, women that don't want to have a C-section might choose another doctor. This would also show transparencies with doctors' actions and protocols. For example, if a doctor skips a step in hospital protocol and it leads to danger for the woman, it could be a reason for perhaps dismissal of that doctor, or at least for patients to stop using him as their care provider. Limitations of this solution would be that it would be fairly expensive to fund committees with just based on maternal mortality in the hospital, and because of patient anonymity laws, it might be an invasion of privacy to publish medical information even if the patient's name was redacted, and certain information would need to be not disclosed if